All right. Good morning, good evening, good day to everyone. Thank you for joining us today. We have a terrific group to present today and to have a discussion on this Google Hangout. I'd like to introduce the participants. Toshi Furukawa is the chair of the Department of Health Promotion and Human Behavior at Kyoto University Graduate School of Public Health and Medicine. He's deputy editor of Evidence-Based Mental Health and the editor of the Cochrane Collaborative's Depression and Anxiety Group. Emanuel Severus is head of clinical bipolar disorders and outpatient program at the University of Dresden in Dresden, joining us from Dresden. Welcome. And Andrea Cipriani, of course, is the associate professor of psychiatry at University of Oxford and the editor of Evidence-Based Mental Health, the host of this talk, and we'll be joined at some point by Andrew Nierenberg. Andy is a professor of psychiatry at Harvard Medical School and the director of the bipolar disorders clinical and research program at Massachusetts General Hospital in Boston. So we're hopeful that he will join soon. Why don't we begin? Professor Furukawa is going to present his network meta-analysis of maintenance treatments in bipolar disorder. And the question today is, where does lithium fit in the picture for the treatment of bipolar disorder? Professor Furukawa.
Hello. Hi, good morning, good afternoon, and good evening to everyone around the world, I think. Today I'm going to present the results from our network meta-analysis of pharmacological maintenance treatments of bipolar disorder that we published last year in the Lancet Psychiatry. The first author is Tomo Miura, and he and I prepared these slides together. So, in this network meta-analysis, as is the rule in the systematic review, we screened more than 10,000 articles, and then at the end of the day, we arrived at 33 randomized controlled trials that compared any drug against placebo or any other drug. And as a matter of fact, 21 of those concerned lithium, 4 valproate, and so on. And the network of evidence that we identified was as follows. You can see that the majority of evidence concerned placebo or lithium. As you know, in the network meta-analysis, in order to compare one drug against another, like imipramine against lithium, we not only benefit from the direct comparisons, the trials that directly compare imipramine and lithium, but also we join or we combine indirect estimates via, in this case, placebo. So the trials that compare imipramine against placebo and against lithium will be combined, like imipramine, lithium imipramine, and lithium. Or we also combine quadrangular network or indirect comparisons, or even pentangular comparisons like these.
Sorry, Toshi, to interrupt. I can't see the slides. I don't know if the other people can see the slides, but it's still the.
It's not showing.
I can't see. Now I can see them. Okay, sorry.
Yeah, very
sorry.
Good.
Okay, sorry. Probably I will show you again. So the direct comparisons combined with indirect comparisons like these triangular or quadrangular or pentangular comparisons. And combining all these direct and indirect comparisons, the bottom line of the network meta-analysis is shown by this league table, comparing any drug in the network against any other drug in the network. In this network, in this league table, The lower left light blue shows efficacy in prevention of any mood episode, and the right upper triangle in pink shows tolerability, that is, discontinuation due to adverse events. However, as you can easily see, this is really a lot of information. So we really wondered, how can we make it accessible and clinically interpretable? One benefit, or one usual way to show the overall picture of the network evidence, is the so-called SUCRA, surface under cumulative ranking. This shows the ranking of the alternative treatments in the network. So here you can see that all the treatments were better than placebo. Placebo PLB is at the bottom of the ranking, and the top ranking treatment was aripiprazole plus valproate, and the second best treatment was lithium plus oxcarbamazepine. However, as you can see, in any treatment, we should be looking at both the benefits and the harms, that is, effectiveness and side effects. And then, so we figured that we can probably take advantage of the two-dimensional presentation in this scatter plot, showing effectiveness on the x-axis and the tolerability on the y-axis. Here you can see that all the treatments seem to be better than placebo, which is in the center of this scatter plot, and aripiprazole plus valproate or lamotrigine may be better tolerated than placebo. But this is again a little bit strange, and if you go back to the network of evidence, you can see that the treatment aripiprazole plus valproate is only connected to the network by this one single trial. And lithium plus oxcarbamazepine is also connected only by one trial to lithium. And it seems that all these standalone nodes are behaving somewhat strangely, presumably because they are unduly influenced, their effectiveness is unduly influenced by one single comparison, and their efficacy estimates are not taking advantage of this whole network. So the next thing we did is to show or gray out all those standalone nodes, and then we focused on the treatment options contained in the main network. And this two-dimensional scatter plot is probably a better representation of the total evidence that we have. But this is still probably unsatisfactory because all estimates of effectiveness has their 95% confidence intervals or uncertainty around it. And this scatter plot does not show the uncertainty around their efficacy estimates. So at the end of the day, we showed, we used what we call the ranked forest plots with point estimates and their 95 confidence intervals. I hope you can see these plots well. They may be too small on some screens, but lithium, the first line shows the efficacy or effectiveness in preventing any mood episode relapse, and the second line shows the effectiveness in preventing manic episodes, and the third line, effectiveness in preventing depressive episodes, and the fourth line shows tolerability or dropouts due to adverse events, and the last line shows the tolerability, the acceptability, that is dropouts for any reason. So all in all, lithium has been found to prevent not only any mood episode relapse, but both manic and depressive episodes. And although it is associated with more dropouts due to adverse events than placebo, its overall acceptability is better than placebo, and the quality of evidence behind lithium was rated with 3 pluses. I will talk to you about this later if there is any time, but this shows that there is moderate quality of evidence supporting lithium. And we concluded in the paper that lithium will remain the first-line treatment for maintenance treatment of bipolar disorder. But the 6 agents may be preventing any mood episode, but may be good for either depressive or either manic episode, and also the quality of evidence may not be as good as lithium. So we concluded that these 6 agents, lamotrigine, lithium plus valproate, or olanzapine, or quetiapine, or risperidone, long-acting injection, or valproate, may be the second or the third line choices in the maintenance treatment of bipolar disorder. And imipramine and lithium plus imipramine are not good for preventing depressive or manic episode or any mood episode relapse, so they will not be a treatment choice usually. So this is the bottom line of our network meta-analysis involving 33 randomized controlled trials. So we would perhaps like to discuss these results, and then if there is time, I would like to discuss how we evaluated the quality of evidence in the network meta-analysis. So to you, Michael.
So Toshi, this is very important evidence that you presented. Is that lithium appears to have the prevention of manic and preventable, but also primarily the use of valproate or divalproic sodium depakote here in the United States. So how does your analysis affect how clinicians should make decisions regarding that kind of prescribing for the American audience here?
So surprisingly, valproate did not fare very well because although overall it was effective in preventing any mood episode relapse and probably against manic episode relapse, but it was not found to be effective in preventing depressive episodes. So as you can see, the adverse dropouts due to adverse events seem to be lower, although not statistically significantly, than many other agents. So that valproate may be acceptable or tolerable, but may not be as effective as we wish it to be.
And why do you say that it's surprising to find that?
Well, because lithium and well, we all accept, or should I say, we have been accustomed to accepting that lithium as the standard drug, and valproate, as you say, has been regarded as one of the standard drugs in the maintenance treatment of bipolar disorder, I think. So from that perspective, it was surprising to me personally.
I see. I see. Others have comments?
Yes, I have a comment.
Andrea.
Sorry, can you go back to the slide and possibly enlarge a bit the, well, I think we are not interested in not a treatment choice, so the bottom part of the graph is not interesting, but if you can magnify a bit the graph and the forest.
Okay. You mean like that?
Yeah, the resolution is not great, but yes, it's better. So just to help me interpret this first plot, lithium is the first choice, and the second part with the light blue um, square, where there are many treatments. Are they in alphabetical order? Are they in order of efficacy? Can you comment on this graph?
Each agent has its pros and cons, so to speak, has its characteristics. So these second and third line choices are listed in their alphabetical order, not in their order of recommendation.
Okay. And so the first, yeah.
Is this better?
Yeah. Yes. So the first, for each drug, the comparison is with placebo.
All these estimates are in comparison with placebo, yes.
And it is overall efficacy in terms of any mood prevention of any relapse, any mood episode, and then it is split into the two different, maybe manic or depressive episodes.
Any mood episode, then manic episode, then depressive episode, then adverse events, then total dropouts.
Okay. And so my question is probably this needs to be contextualized with the grading of the quality of the evidence, but it is quite striking also the results in favor of Quetiapine. So you commented on Valproate, but can you spend a few words about Quetiapine to help us interpret today?
Yes, lithium and quetiapine were the two drugs which were found to be effective not only in preventing any mood episode relapse, but in preventing both manic and depressive relapses. You can look at these three blue uh, point estimates and their 95 confidence intervals. For example, olanzapine is effective in preventing any mood episode relapse and also the manic relapse, but not for depressive relapse. By contrast, lamotrigine is effective in preventing any mood episode relapse, but not manic episode relapse, and effective in preventing depressive mood episode relapse. However, the quality of evidence behind all these agents are shown by these circles, and the quality of evidence behind quetiapine is only low. So 1 plus is very low, 2 plus is low, 3 plus is moderate, and 4 plus is high quality of evidence. So we reasoned that the recommendation for quetiapine should be weaker than the recommendation for lithium. That's why we placed quetiapine among the second or the third line treatment options.
So Toshi, would you be willing to say a bit about how you determine the quality of the evidence?
Okay, let me go on and show you what we did. So, okay, so how do we evaluate the quality of evidence showing NMA, network meta-analysis? Because network meta-analysis has many comparisons, and it is almost certain that confidence in estimates will vary from comparison to comparison. So the quality of evidence should be evaluated for each comparison. How do we do that? In the appendix 11 to the publication, we showed how we evaluated the quality of evidence using GRADE framework. I hope many of you are familiar with GRADE, which assesses the confidence or they tend to nowadays call it certainty, of the point estimate derived from a systematic review in 4 grades of high, moderate, low, and very low, as I suggested. And if it's a systematic review of randomized controlled trials, you start from high, but grade down according to 5 aspects of the evidence. So, sorry about that. So I will show you how we quantitatively assessed the study limitations behind each comparison in the network meta-analysis. As you recall, the network estimates consist of combinations of direct comparisons. So we first assessed the quality of direct comparisons using the Cochrane risk of bias tool. So the direct comparison here, placebo versus lithium, for any mood episode relapse was rated as at high risk of bias, whereas the direct comparison placebo versus lithium against depressive episode relapse was rated as moderate quality, and so on and so forth for each direct comparison. And in the network meta-analysis, we can calculate a so-called contribution matrix of the direct comparisons to mixed or indirect comparisons. That is, I hope you can see this a little bit more clearly. Yeah. So the mixed or the network comparison of placebo versus lithium derives 27.2% of its evidence from the direct comparison placebo versus lithium, and 5.3% from placebo versus Valproate, and 13.7% from the comparison placebo versus lamotrigine, and so on and so forth. So by multiplying these proportions of contribution by the quality of evidence of each direct comparison, we obtain a figure like this. So this shows that the network comparison placebo versus lithium derives close to 80% of its evidence from studies at high risk of bias, and the remaining 20% from moderate studies at moderate risk of bias, and a very small proportion from studies at low risk of bias. By contrast, for example, the comparison placebo versus risperidone derives only 20% or so, less than 20%, from studies at high risk of bias, and the majority from studies at moderate risk of bias. However, in the bipolar maintenance network meta-analysis, there is another layer of study limitations, that is, enrichment design of the included studies. By enrichment, we mean the study limit, the methodological limitation of the study when you include the patients stabilized on drug A, and after being stabilized on drug A, you usually randomize the patient to either continue on that drug A or to placebo. Inevitably, then, we assume that patient will be will be more strongly favored in prevention of the original episode polarity, but not in the opposite episode polarity. So if a patient is stabilized on drug A in the depressive episode, and then after being stabilized, randomized to continue on drug A to placebo, then he's more likely to be prevented against depressive episodes, but not against manic episodes. So we also took account of those enrichment studies and then calculated by using the contribution matrix the same way, and then we can see that the comparison placebo versus lithium received contributions from enriched studies in favor of the lithium, only this proportion, whereas, for example, the the network comparison placebo versus olanzapine received 50% of its evidence from studies enriched in favor of the olanzapine. Likewise, the network comparison placebo versus quetiapine, a little bit like 40% and so on. The same applied to depressive relapses, so that, for example, in the network comparison placebo versus quetiapine, 40% of the trials, of the evidence, came from enriched studies in favor of quetiapine, whereas the network comparison placebo versus lithium, only 20% or less than 20% from studies in favor of lithium, and the similar proportion of evidence coming from studies in disfavor of lithium. So, all in all, we use this. I hope you can see them. So, we assess the study limitations or the imprecision or the heterogeneity and the indirectness and the publication bias of the network estimate of lithium versus placebo. And I should not go into details, but looking at all these 5 aspects of evidence for the network estimate of lithium versus placebo, we concluded that only the study limitations or the risk of bias for the comparison lithium versus placebo was substantial, so that we downgraded the level of evidence for the lithium versus placebo by 1 level. On the other hand, for quetiapine versus placebo, we had to downgrade 2 levels due to study limitations and also heterogeneity. The evidence behind quetiapine versus placebo was very heterogeneous due to the high I-squared percentage here. So we downgraded the level of evidence behind quetiapine versus placebo by 2 to low. So we did all these for all the major comparisons. And yes, and for example, for olanzapine versus placebo, we had to downgrade by 1 level. So the level of evidence behind olanzapine wasn't that bad. And finally, we arrived at these level of evidence estimate. Oops. So moderate quality of evidence for lithium and the low level of evidence for these 5 agents, but moderate quality of evidence for olanzapine, but olanzapine was not found or not yet shown to be effective against depressive episode relapses. So all these 6 agents were regarded as 2nd line to 3rd line treatments for bipolar maintenance treatment. Have I answered your question, Andrea?
Yeah, and I don't know if you can hear me, but very interesting. And my question is now to the panel of experts, because it seems to me that the evidence in favor of lithium is quite robust, also considering that the great majority of studies you have included as a comparator for new drugs like quetiapine. So it's very unlikely it has been favored by the sponsorship bias. So with such a robust evidence, do you think that the clinical practice will change according to these results, or people and clinicians and patients are still worried about the side effect profile, cardiovascular, renal impairment, a lot of discussion about pathogenic effect of lithium, even though there are new data showing that it's not so. risky for patients. So I wanted to ask Michael and Emanuel about their practice and what they think, if these results may have an impact on clinical practice.
Andrea, it's a little bit difficult to hear you, but Emanuel, please make comments about the presentation, which I think was really quite enlightening. And Toshi, I'd like to thank you very much for doing such a terrific job explaining what is otherwise a very complex subject.
Yeah. Well, yeah, first of all, I think that's a very important study, and as well regarding our clinical practice. And as you might know, we also, together with Matthew Taylor, John Geddes, and of course Michael Bauer, did a lithium meta-analysis which was published last December in the International Journal of Bipolar Disorders, and we arrived at very similar results and conclusions regarding depressive, manic mixed relapse recurrence, but also regarding tolerability and acceptability. And I think what's important to highlight is especially the issue with acceptability. So if you look at dropouts for any reason, lithium has still a significant advantage compared to placebo. And I think this is something important for clinical practice. And regarding the tolerability issue, for example, if you look at those studies which were included in this network meta-analysis, often lithium levels were quite high, sometimes up to 1.2 millimoles per liter. And as we know, side effects increase with higher lithium or plasma levels. On the other hand, we think, or the evidence is quite strong, that levels higher than 0.8 milligrams per liter, millimoles per liter, do not confer additional benefits. So in clinical practice, tolerability may even be better than these studies suggest. And maybe coming back to your first issue or first point, yes, I think in many parts of the world, lithium is underused given the evidence we have.
Andrea, you have a comment about that? Toshi?
Yeah, I think.
Yes, Emmanuel, I think you made a very good point that lithium is more acceptable than placebo, despite the high dose of lithium used in many of the old studies. And also, lithium, we included all the trials, so that we included many old trials as well, which were not of high quality. But even taking account of that limitation in study quality, lithium still stood out as the best in terms of many aspects as far as this network meta-analysis is concerned. But just as you may wish to comment, there are other aspects that Andrea suggested that we have to take into consideration when we choose the agent for a particular patient, like the renal function, or also the cardiovascular burden, and so on. So these are the rough guidelines, and then each patient should be given the full consideration for his or her characteristics.
We have a question on the chat from Sina Fazal, who's asking to what extent the Quetiapine findings, which appear to be quite strong, are influenced by publication bias specifically.
It was, in the network meta-analysis, it was difficult to assess the degree of publication bias, except for lithium, for which we had an enough number of studies. Quetiapine was studied in only in 4 studies or 3 studies. I forgot. And yeah, only in 3 studies, and it was very difficult to rate the influence of publication bias. But
so I do have a question, I think, about something that may not be answerable, but may have an impact on how the data get used, which is one of the things that we seem to not necessarily know when we're compiling studies like this and doing this kind of analysis is for each individual study what specific methodologic issues there might be. For instance, I'm particularly concerned with the Quetiapine studies, for example, that in their maintenance trials, the Quetiapine dose was quite high, which was, I believe, 600 milligrams or 600 to 800 milligrams, and people had their dose discontinued over, I think it was 1 to 2 weeks. And so it was at the discretion of the investigator. And so there's the question of kind of placebo unblinding, and in those studies in particular. And I wonder if it's possible, Toshi, to comment about that effect and whether there's any way to control for that in the kind of analyses that you're doing.
Just as you pointed out, we were also very concerned with the high dosage of quetiapine used in those trials. And we agreed that they are far from our clinical experiences. But it was very difficult to assess the impact of that high dosage, because all the studies were used high dosages. So it may be we may need another or other trials that would use lower dosages of quetiapine. Otherwise, we can't know what that influence, what the influence of that high dosage really was on the estimates we have here. Andrea, we discussed this times. So what do you think?
I agree with you that it is. Well, there are 2 issues. One is, methodologically speaking, it's always difficult to lump together studies that we know have subtle differences, and we want an average effect, but everybody knows that it is not evidence-based medicine is not a cookbook. So we have to interpret the findings and try to tailor this data according to the individual patient. The other thing in terms of dosage that is the dose of lithium, because there's a lot about the minimum dose of lithium, whether to increase it up to 0.8, 0.9, or keep it 0.4, 0.5. And I wanted to ask Emanuel, which kind of dose do you use to maintain treatment in bipolar patients?
Well, I think the evidence today points to the fact that for maintenance treatment, long-term treatment, 0.6 to 0.8 is the range we should go for. Higher doses do not seem to give additional protection against new episodes, but will go along in general with more side effects and a higher risk of intoxication. So yeah, if someone experiences further episodes on proper lithium dosage, it might be more helpful to add another drug than to further increase the dose. There was something I wanted to add to the question of unblinding. I think that's a very important point. At least judging from what patients tell me, it's hard not to notice to take 300 or 600 milligrams of quetiapine a day. And so when this is tapered off over a period of 2 or 4 weeks, or many patients do seem to know that they don't receive the drug anymore. And this is kind of learning effect as well. And giving the psychological aspect of knowing not having any more protection, this might also lead, at least potentially, to an increased risk of recurrence or relapse. And the other issue was regarding acceptability or tolerability, because most of the drugs like quetiapine and olanzapine, it was said, were given for an acute episode primarily, and only those who responded and who tolerated this drug were then randomized to further treatment. And so if we look at the tolerability issue, I think it's not amazing that lithium doesn't do so well compared to the other drugs, because patients were not stabilized on lithium. So I think there's a bias really in disfavor of lithium when comparing to the other drugs.
Yes, that is true. The lithium did not receive much contribution from enriched studies. So the evidence for lithium is stronger from that perspective as well.
And we have really I think all of us have patients who are treated for an acute depressive episode in the context of bipolar disorders with quetiapine, and they may do better regarding efficacy, but they do not tolerate it in the long term. And in those studies here, only those who did tolerate it for an acute episode were then randomized. And I think this is an important issue.
Yes. Yeah, and so we have a lot of limitations in the data based on the idea that many of these trials are done by pharmaceutical companies with an aim to get their drug registered for use in places. And so, of course, there is the that will maximize the will have a positive result. And Toshi, there has this sort of effect does something to the data that will tilt the meta-analysis in their favor.
Michael, sorry, I could not hear the first part of your question. Could you repeat your question again?
Sure. What I was saying is that because many of these studies, to address what Emanuel is bringing up, many of these studies are from enriched designs, but they're also done by companies of drugs. That a given will look good in there, even though the studies may not, even though the studies may be high quality. To what extent does that sort of play on?
Yes, we examine the effects of sponsorship bias from two standpoints in this network meta-analysis. So when we rated the quality of evidence or risk bias of included studies, we also took account of sponsorship bias. So you will notice that overall the quality of evidence for each comparison is rated low or moderate at best. That is partly because of the sponsorship bias that we noted. However,
I mean, go ahead.
Yeah. However, we also examine the influence of sponsorship bias by a method called meta-regression. And no, by giving less weight to the sponsorship biased studies, but that did not change the overall estimates in the network meta-analysis. So overall, the sponsorship bias is weakening the evidence we have, but still not, we don't think it had a very particular strong influence on estimates that we have as the results.
Emmanuel, does that address your question, or is there something else you'd like to ask or add about that?
I think this is very important and good answers. There's one more question I had. Probably it's not possible to answer it, but in the paper, it's often said, and I think it's true, that we really don't know whether it's about relapse or recurrence. Do we have, or do you want to comment on this, Toshi?
So the relapse is defined as the resurgence of symptoms from the same episode, whereas recurrence is the emergence of a new episode. But after someone is stabilized, that is, their symptoms are abated by a certain drug, then coming back of symptoms after that point is very hard to say whether it's a recurrence, relapse from the same episode, or recurrence from the for the new episode. And of course, if you had an episode of the opposite polarity, it's bound to be a recurrence, but not a relapse. But otherwise, it's very difficult. And we had a similar problem in the study of prevention of new episodes or maintenance treatment for unipolar major depression. And cutting the thresholds of, how can I say, the interval by 3 months or 6 months or 12 months did not really change the estimate for the relapse prevention. So it means I think we have a continuum of relapse and recurrence, and it's not meaningful to distinguish between these two concepts. They are only in our heads, it seems, not in the reality about the patients.
Thank you.
So given that many of the studies that you show are from commercial entities, how surprising do you think it is that lithium rises to the top of this? In other words, even if you control for commercial bias, still the numbers of subjects and the that you have is very high in the commercial trials. Is it surprising at all that a drug that doesn't have commercial support like lithium would end up both having high quality evidence and having an effect that where the confidence interval shows support for prevention of relapse to any mood episode, depression, and mania?
I personally was surprised that lithium came at the top. I thought it would be one of the good ones, but I didn't. I had not. It's just for the reason you said. I did not expect lithium to come that high. Yeah, that's for sure. But the nature of evidence, even though the quality of evidence of the old small trials were rated poor, but because of the how can I say, the counter enrichment design that used in the more recent trials, which had higher methodological quality, showed lithium to be a very viable choice in the maintenance treatment. Yes.
So what you're saying is, for instance, like in a lot of those data come from the lamotrigine trials. You're saying that there's reverse enrichment for lithium. That is,
I think so.
Okay, can you Can you say a little bit more about that?
Yes, if you look at, I'll show my slides again, and okay.
Okay.
So here, the contribution from enriched studies in the prevention of manic episodes, the evidence for lithium came only 10% or so, less than 10% from enriched in favor of lithium, and the same proportion from studies enriched in disfavor of lithium. So they really cancel each other. And the majority of the evidence came from non-enriched studies.
Okay. Oh, very good. Well, that's important to point out.
And if you look at olanzapine, quetiapine, and risperidone, they come from heavily enriched studies.
Right, and these, as Emanuel pointed out, are studies in which the patients both tolerate the drug and respond to the drug.
That's very true. So in this analysis, we only consider the efficacy in terms of prevention of manic or depressive episodes, but this same thing should have influenced the tolerability as well.
So the reason it would affect the tolerability is that the subjects who are not able to take the drug are eliminated from the studies, thereby leaving the people who remain in the studies to be people who have already proven that they tolerate the drug.
Exactly.
Nasir Gami, who's at Tufts University in Boston, likes to give I think a humorous anecdote about enriched designs. He asks the audiences when he gives talks sometimes for people to raise their hands whether they like vanilla ice cream, and then he asks other group then he asks people to raise their hands if they prefer chocolate ice cream. And then he says, I'm going to take all of you who like vanilla ice cream, and I'm going to randomly assign you to get either vanilla or chocolate, and then we'll see what the results look like. So it's really it's a really quite nice anecdote for kind of explaining it, because what you're doing is you're finding the people who like the drug in many ways, right? They like it because they respond to it, they like it because they can tolerate it, and then you randomly assign them to take something that they may not like. I think that's part of the issue with the drugs, and so you can really see with the olanzapine, the quetiapine, and the risperidone LAI that has a very large impact on the effect that we're seeing.
And maybe one final point to what you said. An issue I think which is also open discussion is that in the question is in many of those trials or seeking trials for those new drugs, many patients were on lithium before in the past at some point. And together with Mauricio Tone and Ilya Lipkovich, we analyzed whether this was a risk factor for relapse or recurrence. And what we found, and this was interesting, is that having been on lithium in the past was a risk factor for depressive relapse or recurrence. So what might happen is that patients are enrolled in those studies who did have some benefit of lithium, but not really were doing very well. So there may be another bias in disfavor of lithium.
Right. Well, you mean a bias in favor of lithium, or
in
a
disfavor?
Bias in favor?
So, because those who were on lithium in the past did worse than those who had never been on lithium.
I see.
I mean, this makes clinical sense that if someone was doing very well on lithium, why switching to a new drug?
Exactly. Right. So this would be that would mean that it would be biased against the lithium. That is,
Yeah.
that people who have done poorly before are likely the ones who are being randomized to it.
Well, they had only a modest benefit. And if you look at those studies, often approximately 2/3 of those who participated had been on lithium in the past.
Right. I did want to raise one more question while we still have a little more time, also raised by Sina Fazal, is what is is there a recommended minimum level of primary trials to do a network meta-analysis? Is that a question you can answer, Toshi?
You mean the minimum number of trials for the network meta-analysis? Was that your question?
Yeah, I'm not sure I quite understand. I'm not sure I quite understand the question, but are there a minimum number of subjects or a minimum number of trials themselves that you would use, or does that number really just affect the confidence interval?
As far as I am concerned, I think the most important thing for before doing the network meta-analysis is how well connected each node is in the network. So, just as I showed, standalone
to think about your initial slide. Oh, I see.
Yeah.
So the nodes that have thicker bars connecting them, or larger nodes, are the ones that are most important.
The most important, and also somehow making closed circles, closed triangles. So standalone nodes are very dangerous, but so long as the networks are connected by closed loops, they would form a very good candidate for network meta-analysis.
I see. And if people are able to switch to that, okay, to see that. Oh, that makes sense. Oh, I see. And there are unclosed triangles there that you don't want to make that you don't want to draw great conclusions from.
Right.
Well, we have only a couple minutes left. Perhaps you can just say a little bit about how a clinician might want to implement this kind of finding in their own work.
Yes, my other comment regarding our results is that lamotrigine did come out as being able to prevent any mood episode relapse, but it was much weaker than the others, and it was not effective against manic relapses. So this is very different. And then probably the last slide I would like to show is, I don't know if people would like to show, like this idea. So different agents are more suited to prevent depressive episodes or manic episodes. So if you use this two-dimensional plot, then you can see which agent is more able to prevent manic as opposed to depressive episodes. So depending on the patient's past history, this is another consideration you would like to give in choosing the agent for that particular patient.
I see. So drugs like Quetiapine appear to have a stronger effect because they're farther to one side of the line compared to olanzapine, which also is far from the line for a mania-dominant dropout effect. I mean, prevention effect. That's very good. All right, well, we're coming to the end of our hour. I wanted to thank everybody for joining us. Professor Toshi Furukawa, again, thank you so much for your wonderful presentation of a very complicated subject and some really terrific research. And I certainly know for me that I have a better understanding of how to interpret these data now than I did before. And Emanuel, Severus, and Andrea, Cipriani, thank you for joining us. And before we finish, I do want to mention again Holly Millward, who is behind the scenes at Evidence-Based Mental Health, making sure that we can get these off the ground. And so, Holly, much appreciation to you. Andy Nierenberg was not able to join because of technical problems, and that's always going to be an issue now until everybody in the world has high-speed fiber internet connections. Until then, some people are going to not have the bandwidth to join. But please check again at our website for our next hangout, which should occur in the next few weeks. So I appreciate everybody joining us. Thank you very much.
Thank you. Thanks to all.
Enjoy your